Dear friends, in this video, we will talk about some recent updates on community-acquired pneumonia, which is one of the leading causes of ICU admission in our country. Let us start with an illustration of a case of a 55-year-old male with fever, cough with expectoration, and dyspnea for 3 days, presents to the emergency room. The patient is a chronic smoker with 40 pack years of smoking history. He is diabetic for the past 10 years and hypertensive for the past 5 years and on irregular medications on all of these accounts. On examination, patient has a respiratory rate of 24, blood pressure is 110/60, heart rate is 114, patient is febrile with a temperature of 101 degree Fahrenheit and saturation on room air is 85%. On auscultation on chest, there is reduced vesicular breath sounds on the right and with bronchial breath sounds on the left. The chest X-ray also shows features of consolidation on the left with minimal pleural effusion on the right. On investigations, the TLC count is 20,000 with predominantly polymorphs. The CRP is raised. Blood glucose is also very high. So initially the patient is put on oxygen, started on intravenous fluids, antibiotics, insulin to control, soluble insulin infusion to control the blood glucose with pantoprazole infusion, and also the taken care of for the nutrition and others, and hemodynamic monitoring is instituted. Now, the first question that arises is that, is this severe CAP or a non-severe CAP? Now, to understand and assess the severity, if we follow the ITSA or the ATS criteria, we will find that there are certain major criteria as well as there are certain minor criteria. The two major criteria include septic shock requiring vasopressors and respiratory failure requiring mechanical ventilation. There are 8 or 9 minor criteria, which includes respiratory rate of more than 30 beats per minute, the PF ratio less than 250, multilobed infiltrates on chest X-ray. Patient is either confused or disorientated on CNS examination. Blood urea nitrogen more than 20. Patient is leukopenia with WBC count of less than 4,000, which can indicate infectious origin, or thrombocytopenia with a platelet count of less than 1 lakh. Hypothermia, less than 36 degrees core temperature, and hypotension requiring IV fluids. Now, if a patient satisfies one major or 3 or more minor criteria, then this patient should be considered as case of severe pneumonia. Otherwise, the patient is non-severe pneumonia, non-severe community-acquired pneumonia. Now, the question automatically comes that what are the other scoring systems, or is this the standalone systems? No, there are other systems also. The most commonly used is the CURB 65 scoring points, where the acronym CURB itself suggests the features. C stands for confusion, which is defined as a mental test score of less than equals to 8, or disorientation in person, place, or time, which is given 1 point. Uremia, that is blood urea of 19 milligrams per deciliter roughly, which corresponds to more than 7 millimoles per liter, 1 point. And similarly, respiratory rate of more than 30, systolic blood pressure of less than 90, or a diastolic of less than 60, each gets 1 point. Age more than 65 years gets 1 point. If the patient has a score of 0 or 1, then the mortality risk is very low, of 1.5%, and the treatment options are to consider home treatment. If the score is 2, then the mortality risk is intermediate of 9.2%, and one should consider hospital supervised treatment, either short stay inpatient or hospital supervised outpatient. If the score is more than 3 or equals to 3, then the mortality is much higher, almost 22%. And there the patient has to be managed in hospital as a severe pneumonia. And we can consider admission to the intensive care unit, especially if the CURB 65 score is 4 or 5. So this can be used conveniently as in the emergency department to stratify the risk. And it is in this setting that it has found extensive usage. Now, in addition to that, if you look into the chest X-ray, there is another score which can be confirmed, and if it is confirmed on chest X-ray, and we can use this SmartCop score, which is a score, as we can, it's also an acronym. Systolic blood pressure of less than 90 is given 2 points for both patients who are more than 50 years or less than 50 years. And it's almost similar with multilobar chest X-ray involvement, albumin less than 3.5, respiratory rate of more than 25 in cases of 50 years, more than 30 in case of more than 50 years old. Tachycardia is similar, that is 125 or more. Confusion, also given 1 point. Oxygen is low in the form of PO2 less than 70 or saturation less than 93 or PF ratio less than 333 in case of 50 years old or less, whereas PO2 less than 60, oxygen saturation of less than equal to 90% or PF ratio less than 250 for more than 50-year-old. Again, this is given 2 points, and pH of less than 7.35 is given 2 points for both the categories. So total point score is 11. And if the patient scores between 6 and above, then this patient qualifies for inpatient treatment. If it is between 4 to 6, then patient has to be under observation for some time and then can be sent back home, and less than 4, it becomes to outpatient treatment. If we look into this PSI or the pneumonia severity index or the PORT score, there also they use compound variables in various forms with patients age less than 50 with comorbidities or physiologic REDs, and classify the risk into low risk categories 1, 2, and 3, where 1 and 2 qualify for outpatient treatment. Low risk class 3, outpatient versus observation, depending upon the clinical judgment, whereas 4 and 5 are inpatients, 4 with moderate risk and high risk is 5. Now, it is very important when we to know that when we have so many severity scores, how do they compare against each other in real-time scenarios? The scores are plenty, and we have seen that a lot of them have been validated in different settings, and many of them have been validated across patient populations across different parts of different geographical regions. But what is important to note is that the constituents of this scoring system is more or less the same. Whereas CURB 65, 1 point is even for confusion, ureas more than 7 millimoles, respiratory rate more than 30, systolic BP of less than 90 or diastolic less than 60 and age 65. If we see that the pneumonia severity index, it considers these variables, but increases the number and uses a complex weighted sum. So these are weighted. So definite statistical methods are applied to find out the weighted sum. And 1 point each is given for SWOT score for male, wasting, non-ambulatory, etc. So whenever we see these scoring systems, that the ideal CAP severity could identify the risk of deterioration in patients and indicate a proportionate intervention to maximize the outcome and promote efficiency. So in those patients who require early intervention, these patients are at increased risk of complications. So it is very important to identify deterioration at the earliest. But one thing we have to understand that the severity scores fall short in perfection in 3 areas. And this is true for all the scores that are used today. And one is discrimination, application, and intervention. So prognostication is the area where most of the scores are comparable. But in these 3 areas, there are subtle differences. So which of the scoring system fit best for CAP severity? Now, CURB 65, as you know, is a simple score, and it can predict mortality secondary to CAP, and it is widely used to identify patients who can be managed as outpatients, and it is very useful in the emergency room setting, and that's the reason for its wide popularity. Pneumonia severity index is mainly used to identify low-risk patients with CAP, and the systematic reviews have found no significant difference in overall test performance between CURB 65, CRB 65, or PSI for predicting mortality from CAP. In patients with CAP without contraindications to ICU care, the IDSA adds minor criteria predict subsequent requirement for mechanical ventilation, ICU admission, and or 30-day mortality. There are 9 minor criteria which I had shown in the previous slides. So that illustrates the ITSA criteria. So the ideal CAP severity score would identify the risk of deterioration in patients and indicate a proportionate which can maximize the efficiency. So let us go back to the case. After 2 days, patient is having clinical deterioration. The blood pressure is 90/50. The heart rate is further increased. The respiratory rate is 30. Saturation is 80% with oxygen. Temperature, the patient is still febrile. Chest shows bilateral reduced air entry with crepitations and bronchial breath sounds. Chest X-ray reveals bilateral consolidation with pleural effusion, also more on the right side than left. The counts are almost similar, but the CRP has risen, and so also the PCT. Now, the question answers that, can the patient be treated at home? The answer is obvious that no, this patient should not be treated. It should be administered. But there are also certain other things who should be considered for ICU admission. The signs of deterioration, whenever their patient in presents with 3 or more signs of deterioration, like respiratory rate more than 30, the PF ratio less than 250, multilobar infiltrates, encephalopathy, thrombocytopenia, hypothermia, leukopenia, or hypotension, then probably ICU would be the safe place to prevent their deterioration and to diagnose and intervene early for any complications. So local infection can cause LRTI with mild pneumonia, but when there is pulmonary spread, it progressively causes sepsis, severe sepsis. Severe sepsis is not there as per the sepsis 30, so it goes to septic shock with multi-organ dysfunction. And because of the hypercoagulation and the systemic inflammatory response, the patient develops severe hypotension, which becomes unresponsive to fluid resuscitation over a period of time. So severe CAP is a progressive disease which leads to rapid decompensation, multi-organ dysfunction, and finally, it can lead to mortality. So what should be the empiric antibiotic cover for this patient? Now, most of the treatment guidelines which fulfills our patient's criteria should follow either of the two. If the patient is classified as a non-severe, we have one kind of regime. If the patient is severe, we have a slightly different regime. In a non-severe pneumonia, we can consider monotherapy with a respiratory fluoroquinolone in mild cases, or beta-lactam plus macrolide. The options for beta-lactam being ampicillin, sulbactam, cefotaxime, ceftriaxone, ceftaroline, and that for macrolide being azithromycin or clarithromycin. This is plain and simple, which everyone does. But sometimes it is necessary to add an MRSA coverage. If prior respiratory isolation of MRSA is there, one can add vancomycin in patients with normal renal function, or use dose adjusted based on levels of kidney, or you can start with linezolid 600 milligram IV or 12 hourly. So in recent hospitalization with receipt of parenteral antibiotics and locally validated risk factors of MRSA, it is important to obtain cultures and not start treatment unless the results are positive. Sometimes the MRSA treatment are started quite early, where actually it doesn't, the virus is not yielded. The cultures don't yield the MRSA. So that should be strongly discouraged. If rapid nasal PCR is available and MRSA coverage in PCR is positive while awaiting cultures, it can be started. But after obtaining the culture reports, the treatment needs to be modified. And if the MRSA is not there, it has to be stopped. In cases of severe CAP, we can go for beta-lactam plus macrolide or beta-lactam plus the respiratory fluoroquinolone. The choices of beta-lactam and the macrolides are almost similar. And in fluoroquinolones, other than levofloxacin, one can also use moxifloxacin 400 milligram OD. If prior respiratory isolation of MRSA or recent hospitalization or receipt of parenteral antibiotics or locally validated risk factors for MRSA are present, then one can add vancomycin or linezolid as per the availability and patient's tolerance. Now, another important consideration is to add Pseudomonas coverage. So if the prior respiratory isolation of Pseudomonas is there, then switch the beta-lactam from standard regime to one of the anti-pseudomonal beta-lactams like either piptaz or cefepime or ceftazidime, imipenem, meropenem, aztreonam, etc. So in case of recent hospitalization and receipt of parenteral antibiotics and locally validated risk factors for Pseudomonas aeruginosa, we should obtain cultures and start treatment only if the results are positive. So this is also important. The same precautions which apply for MRSA also applies for Pseudomonas so that over treatment can be prevented. Now the question comes that what are the practical means to consider MRSA coverage? Now there is a score which is known as a SHORE score, which includes age either less than 30 or more than 75 as 1 point, hospitalized more than 1 day in the past 3 months, 2 points, nursing home or facility for the last 3 months, 1 point, IV antibiotics in the last month, 1 point, sick enough to need ICU, 2 points, cerebrovascular disease, 1 point, dementia, 1 point, and female with diabetes, 1 point. So if the SHORE score is 0 to 1, no coverage unless clinically suggestive of MRSA. If between 2 to 5, the judgment call based on specifics of the patient. If the score is between 6 to 10, then we start cover for MRSA. Now, these patients need to be re-evaluated when NAIRS, PCR, and procalcitonin are available. So either 4 of the criteria should be satisfied, that SHORE score is less than 6, the NAIR PCR is positive, clinical judgment, MRSA may be likely or may not be, isn't very likely. Sputum grain stain, if available, doesn't show predominance of gram-positive cocci clusters, or procalcitonin is negative. If answer is yes, we have to stop. We know MRSA coverage is needed. If the answer is no, we have to cover for MRSA and reevaluate for 48 to 72 hours after admission. Again, we have to see whether this criteria are met, that negative sputum culture, or if sputum culture is not available, then negative NAIRS PCR plus negative throat culture. If it is no, then we continue antibiotics for MRSA. So this beta-lactam resistance in MRSA can be a problem due to penicillin binding protein 2A, and one needs to know the local flora and the local susceptibilities of the organisms to antibiotics before resorting to the specific therapy. So what should be the duration of antibiotic therapy? Duration should be guided by validated measure of clinical stability, which is usually 5 to 7 days, because it has been seen on various occasions that long duration of antibiotic treatment makes no difference to the short duration therapy in terms of outcome. But of course, for recurrences, for recrudescence, this has a role. So one should know the resolution of vital sign abnormalities like heart rate, respiratory rate, blood pressure, oxygen saturation. So all those things need to be resolved. They should become normal. Patient should be able to eat and have a normal mentation. Antibiotic therapy should be continued until the patient achieves stability for no less than a total of 5 days. Because if we stop antibiotics before 5 days, it may be too early and there will be high risk of relapse. So what is the role of PCT-guided antibiotic de-escalation? If you look into the chart, you can very see clearly that less than 0.1 antibiotic strongly discouraged, and between 0.1 to 0.25 it is discouraged, whereas between 0.26 to 0.5 it is recommended, and more than 0.5 is strongly recommended. If no antibiotic is initiated, we can repeat PCT within 6 to 24 hours, look into the differential diagnosis, and we can consider antibiotic therapy for admission to the ICU based upon certain features like respiratory instability, hemodynamic instability, or life-threatening morbidities like imminent death or severe immunosuppression, etc. Complications and difficult to treat organisms like Legionella in presence of abscess or empyema in the patient. If the PCT is less than 0.1 or curve 65 is more than 3, and the pneumonia severity score is more than 130, then those are the patients where we need to treat. Otherwise, we will have to figure out the risk that this patient presents with. Similarly, COPD gold stages 3 and 4's saturation less than 90% despite 30 minutes of intensive oxygen. These are all indications to start therapy in presence of procalcitonin values of 0.1 to 0.25. However, one should look for falsely low PCT in patients with parapneumonic effusion loculated infection like empyema, early phase of infections, fungal infections, and more severe immunosuppressive therapies like following cancer or other diseases. So if the antibiotic therapy is initiated, then PCT should be done on control on day 2 to 3, 4 to 5, 6 to 8, and every 2 days after day 8 for the guidance of antibiotic therapy. To stop the ongoing antibiotic therapy, we have to use the same cutoff values as before, or it's as in all. And for initially very high PCT, like if it is more than 5 or so, follow the relative decline if there is a good response, like decline of more than 80% of the peak, we have to stop, recommended to stop antibiotics. If it declines more than 90% of the peak, then stop, strongly recommended. So persistently elevated PCT can be suspected a complicated course like the resistant organism, multi-organ failure, abscesses, etc. Because in abscesses, etc., it will not be able to reach the site of its action. And falsely elevated PCT, like in severe SIRS or shock, ARDS, trauma, postoperative tumor, fungal cases, so or malaria. So here also it will be of lesser significance. So serial PCT measurement is likely to be useful primarily in settings where average length of stay for patients with CAP exceeds the normal practice. So when it is normal in comparison to the normal practice, it matches the normal practice, then there is no need probably to do serial PCT measurements. So now when longer courses of antibiotic are recommended, now in patients with delayed response in certain bacterial pathogens such as Pseudomonas or Staph aureus or Legionella, for complications like empyema, lung abscess, and necrotizing pneumonia, it is desired a 14-day therapy with macrolide or doxycycline will clear or treat tularemia, pneumonia, or psittacosis, and itraconazole is the drug of choice for pneumonia caused by coccidioidomycosis or histoplasmosis. So once we know the few rare causes for which prolonged treatment is required, for the all other cases, we can continue with the standard treatment. Now, chest tube placement will be needed to drain an empyema, and in case of multiple loculations with surgical decortication, because unless and until this source control is adequate, the patient will not recover. And these are very important steps for source control. Now, what to do in patients with CAP who test positive for influenza? Anti-influenza treatment is recommended for inpatient setting, independent of duration of illness before the procedure. But one thing is very important to realize that the benefits are strongest when therapy is started within 48 hours of symptom onset, and this is continued thereafter. So Staph aureus is the most common bacterial infections associated with influenza pneumonia, followed by Streptococcus pneumoniae, H. influenzae, and Group A Streptococcus. However, in patients with CAP, a positive influenza test, no evidence of bacterial pathogen, early clinical stability, in all those cases, consideration should be given to early discontinuation of antibiotic therapy at 48 to 72 hours. Although there are some benefits, but limited benefits, evidence about the benefits, and the risk of harm is also there. Now, when can steroids be used in patients with severe CAP? Now, CAP and refractory septic shock to adequate fluid resuscitation and vasopressor support are probably good enough reasons to think about steroids. But the side effects of steroids on the order of 240 milligram of hydrocortisone per day include significant increases in hyperglycemia requiring therapy, and also possibly higher secondary infection rate. One need to be more cautious about this. There is no data suggesting benefit of corticosteroids in patients with non-severe CAP with respect to mortality or organ failure. So non-severe CAP, there is no point in trying to use them. Clinically appropriate use of steroids for comorbid disease such as COPD, asthma, and autoimmune disease, where corticosteroids are supported as a component of treatment, are allowed. So we will have to figure out with a lot of difficulty that when steroids can be required. But one thing is sure, that it is not required in mild to moderate cases. If we look into the 2019 and 7 guidelines, we can find there are a lot of differences, but the major differences in the guidelines of the ATS and the ITSA is that in the 2007 guidelines, the procalcitonin was not that widespread relevant, so it was not covered. Use of corticosteroids are not covered. So in 2019 guidelines, also procalcitonin is not recommended to determine the need for initiating antibacterial therapy. It is only for de-escalation. And regarding the use of corticosteroids, it was recommended not to be used. It was only considered to be used in patients with refractory septic shock. So this is as per the 2019 guidelines, and it was not covered in 2007. Similarly, the routine use of follow-up chest imaging is not recommended currently because patients may be eligible for lung cancer screening, which should be performed in the clinically indicated patients, and the same should be noted. So what are the possible course of complications during severe CAP? So there is pneumonia. There can be local inflammation or there can be systemic inflammation. If there is local inflammation, there can be VQ mismatch, hypoxemia, and cardiovascular events. If there is systemic inflammation, then there will be some pro-inflammatory cytokines will be released, some anti-inflammatory cytokines will be released. However, all of this together will have prothrombotic effect, will also have some atheroma instability, increased fibrinogen, rupture of atheromatous plaque, and all of this, including the endothelial dysfunction, will lead to hypoperfusion, leading to organ failure. So what are the acute and chronic assessment during community-acquired pneumonia? Now, when the patient comes early, during the first 4 to 8 hours, we have to assess the severity. The site of care has to be decided, send the microbiological tests, give empiric antibiotics, and institute the supportive care. Till 72 hours, we have to check what is the patient's clinical stability, the radiological results, reassessment of antibiotics, including stewardship, switch to oral antibiotic form, as well as the duration. Next, after 72 hours, it is the reassessment time, where clinical reassessment, which may necessitate repeat microbiological tests or may require change in the antibiotic based on the culture reports, and one can consider or repeat chest X-ray or a CT scan, as the case may be. At the time of discharge, one should consider vaccination, rehabilitation, reintroduction of previous drugs, and chest radiograph for some patients. So here you can see the graph where there can be deviation anytime after 72 hours or at the discharge time in terms of the severity. So my take-home message would be that community-acquired pneumonia is a leading cause of hospitalization, mortality, which incurs significant healthcare costs. Determining the appropriate level of care is very important for improving outcomes, in addition to early diagnosis and timely treatment. For patients with a CURB 65 score of greater than equals to 2, inpatient management is recommended. The recommended duration of therapy is 5 to 7 days in patients with a favorable clinical response, such as absence of fever for more than 48 to 72 hours, or not requiring supplemental oxygen and resolution of tachycardia, tachypnea, and or hypotension. All adults 65 years and older and those considered at risk for pneumonia must receive the pneumococcal vaccination. So this is in a nutshell about some of the interesting updates from community-acquired pneumonia, which we are all aware of. Thank you very much for your kind attention.